Just by way of preliminary introduction, my name is Quintin Dealey. I'm a consultant psychiatrist and academic at the Institute of Psychiatry, Psychology and Neuroscience, and I'm the chair of the Maudsley Philosophy Group. And I've had the pleasure of knowing Vaughn for many years now. Vaughn has an interesting and varied intellectual and professional trajectory. He did a PhD in cognitive neuropsychiatry before going on to do a DClin Psy in clinical psychology. And his work is really matched by a tremendous breadth of clinical and scientific interests, both in research, but actually also in the public communication of science as well. And so Vaughn presently is an associate professor in clinical psychology based at UCL, but with a clinical appointment at the Maudsley Hospital working with people with psychosis. So Vaughn, I could expatiate much more about your many achievements and interests, but I think that's probably sufficient to set the scene for today's talk. And so thank you very much, Vaughn, for sharing this talk with us about a really fascinating topic within really important, not just conceptual aspects, but where conceptual aspects of psychiatry and neurology really do make a difference to how we think about the difficulties that people have and how we do or do not help them. So I'm going to hand over to you now to Vaughn, just to invite you to begin the talk.
Okay, so not an entirely disinterested introduction from Quintin, considering he was one of the authors of this paper as we developed it. So I'm going to talk about, I'm going to present this. The first thing to say is that it's published as a paper you can just get from the internet, which possibly will be a slightly more coherent version of what I discuss. However, what I want to do is just introduce some of the folks involved in this. So myself, Sam Wilkinson, who's a philosopher of mind, psychiatry and medicine, who may be in the audience, Monica Greco, who's a sociologist of medicine, Callan Hendry, who's a survivor of brain injury, Ben Mills works for Head of East London as an advocate for people with brain injury, and Quintin, you know, is a consultant psychiatrist. So this was a really kind of interdisciplinary look at the functional organic distinction, which has fascinated for many years for the fascinating scientific problems that come up, the infuriating political issues it raises, and through lots of very tedious discussions in ward rounds and team meetings about whether something is a functional organic problem that someone has. And so this really came out of a kind of fascination, dissatisfaction, interest from a whole group of different people, just trying to think about actually what is the functional organic distinction doing in psychiatry and psychology. Rather than asking what should it be doing, try and ask what is it be doing, and then what is it doing, and then think a little bit about what are the conceptual implications of that. So firstly, I just want to start off with a bit of a history of the functional organic distinction, because all you need to know is a little bit of history to really understand that the functional organic distinction is not sometimes, as it's portrayed, it has to be said, a like clear-cut distinction between different sorts of problems. So we can really go back to the birth of neurology with Thomas Willis. He was the person who coined the term neurology, and through his anatomical studies connected alterations to the structure of the nervous system to the signs and symptoms that patients were presenting. Now, he was around in like kind of 1600s. And so it was really important that what he was doing is he was matching the visible changes in the nervous system, largely post-mortem, to the signs and symptoms that patients presented. And this pretty much defined organic for several centuries. And this idea that it should be a structural alteration to the nervous system for which one can see is still deeply influential today. As we'll see, there are various things with strong evidence for their, kind of pathology of the nervous system, which are not kind of defined as organic for interesting and curious reasons. But this is really where the kind of concept of organic stemmed from. Interestingly, throughout this time, though, there's always been these two different definition of functional. So one has referred to the physiology of an organ and the other one to the mind, and we're just going to go through them both. So let's think about functional as in physiology. So originally this was any organ, but most commonly the brain. So this was John Hewlins Jackson's definition, the morbid alterations to the normal function of nerve tissue. Okay, so particularly as Hewlins Jackson was talking about, specifically related to altered sensation and motricity. And it included conditions where altered neurophysiology had been confirmed as a cause, such as peripheral paralysis, which you can confirm through neurological examination, but also where altered neurophysiology was presumed to be the cause, but was not confirmed at the time, such as epilepsy. So if we go back to, kind of Hewlins Jackson's day, there was no electrophysiology to speak of. And so it was just assumed that a functional problem included things like peripheral paralysis and damage to the nerves, but also things like epilepsy, which were alterations to the physiology, even though you couldn't see any particular, kind of visual, there was no visual evidence of damage to the nervous system. Sometimes people think the idea of using functional to refer to the mind is new. Actually, it was used way back. So this is a quote from William Cullen, a very influential kind of early neurologist, who said it is very probable that the state of intellectual functions depends chiefly on the state and condition of what is termed nervous power. So he's very clearly using the word function and functional to refer to the function of the mind, in this case, the intellect. This use was popularized by the phrenologists. The phrenologists get a really bad rap these days, basically because their main claim was fundamentally wrong and a bit daft, the idea that bumps on the head could predict your faculties. Actually, the phrenologists were hugely influential and actually did lots of quite sensible work in understanding anatomy. And they were, quite influential in kind of promoting this other concept of functional. But the actual functional organic distinction as a specific explanatory contrast was created in 1893 by William Gowers. He distinguished organic disorders involving structural lesions, in other words, visually identifiable structural lesions, and those involving altered functioning of the physiology of the nervous system. So the idea that even if you couldn't visually identify structural damage, the physiology of that nervous system was malfunctioning. And he listed chorea, paralysis agitans, essentially what we now call Parkinson's disease, tetanus, epilepsy, migraine, writer's cramp, and alcoholism and hysteria as functional. So again, very different from what we might think of as functional today. And later, Freud and the other dynamic psychiatrists took over, according to Reynolds, the words functional to mean their version of psychological. So here, although this use implies a disturbance of the nervous system in the broad sense, the assumption is that such difficulties, the assumption that such difficulties would eventually be explained by specific instances of altered neurophysiology was rejected. All right, there was no idea that you would find a lesion responsible or the functional meant psychodynamic or psychological. So by the mid-1900s, we have this tripartite distinction: organic, explained by structural damage, largely detectable by kind of visual detection of structural damage; functional, meaning explained or potentially explained by altered physiology in the absence of visible structural damage; and functional, meaning explained by psychology with limited interest in or rejection of reductionism. And the cognitive revolution comes along in the 1970s, and we have functional organic very much seen as this kind of software-hardware distinction, very much in line with functionalism and the philosophy of mind. So the reason I'm just kind of going through a brief history is really just to highlight that the terms functional organic have not referred to stable concepts over time. And so we've done this by looking at how functional organic was defined, but you can also do this by looking at how kind of different conditions have been understood. So madness, to give it its historically most kind of appropriate name, has been considered primarily organic or primarily functional at different times by different classification schemes, regardless of the neurological findings. And brain pathologies without structural lesions, such as, in many cases, seizures, have been included in both functional and organic categories. So these stables are not innate, they're not implicit, they're not obvious. They have changed over time and continue to be in flux. And indeed, we still see this kind of controversy ongoing within psychiatry, neurology, medicine more broadly. So this was neurologist Kinnear Wilson, wrote a very well-regarded, influential textbook in neurology, and he wrote in 1940 that the functional organic distinction still lingers at the bedside and in medical literature, though it is transparently false and is abandoned since by all contemplative minds. And yet it remains a kind of topic of controversy. So the DSM dropped the terminology organic after DSM-3. In the DSM-4 and DSM-5, it has things like psychotic disorder due to another medical condition. Although the conceptual basis, it must be said, is largely unchanged. They kind of changed the terminology, but didn't really change much of the kind of underlying conceptual basis. When you kind of look in the DSM and say, what does organic mean? It says things associated, kind of mental disorders associated with alterations to the nervous system, and lists temporal relationship and known associations as guides, but rarely gives specific criteria. So, for example, an organic anxiety disorder is one that is associated with kind of organic damage, but doesn't really tell you how to make that specific association in many cases. If you look in the ICD-10, like in a DSM, the functional organic distinction is a key organizing principle. So, for example, we have kind of mental behavioral disorders. We have a whole other section, the F0 to F9 section, which is essentially repeats in a slightly briefer form all of the rest of that section, but saying that they're organic syndromes, right? So you have organic anxiety disorders, organic depressive disorders, mood disorders, organic psychosis, and essentially says that they're the same, but they're due to the direct physiological effects of some lesion or some disturbance in the nervous system, but there are no specific criteria for establishing organicity. There may be local ones, but there is no kind of like global guidance for doing so. In the ICD-11, they've de-emphasized the distinction as an organizing principle. So kind of mental behavioral disorders are not split by this division between the organic ones and the functional ones. There is to a certain extent, but they've tried much more to group things by disorder. So, for example, all the sleep disorders are now grouped together, and within that, they will be ones which are more directly related to disturbed physiology, ones that are not, such as like primary insomnia and so on and so forth. And it does give a kind of general guide to what counts as organic, which it says is based on evidence from the history, physical examination, or laboratory findings. And this history, physical examination, or laboratory findings has now become a bit of a common, very vague criteria for identifying what counts as organic. So, for example, this is the ICD-11 definition of a secondary anxiety syndrome. So it says, characterized by the presence of prominent anxiety symptoms, judged to be a direct physiological consequence of a health condition, not classified under mental behavioral disorders, based on evidence from the history, physical examination, or laboratory findings. And importantly, it says, this is not a psychologically mediated response to a severe medical condition. So despite it being, a kind of diagnostic category, you still are left with being able to have to understand what's a direct physiological consequence and what is a psychologically mediated response to a severe medical condition. Now, I just want to make a clarification here. What we're not doing is suggesting that, there's no such thing as a difference between functional organic disorders, right? So if someone says, this person has kind of post-ictal psychosis, we're suggesting this is all nonsense, you can't make the distinction. You clearly can. But I guess the part of the reason of this critique is just to highlight, actually, what is the conceptual basis and what do these, what, for example, are the assumptions that the distinction makes in various places, either globally and locally, across psychiatry and neurology. So, for example, here, it makes the assumption that you can judge what's a direct physiological consequence rather than a psychological mediated response. Now, in certain conditions, I'll talk a little bit about kind of anxiety and hypercalcemia later. There are some good, reliable ways of which this can be associated, but in many ways, in many instances, this is not the case. So if someone has a brain tumor and is very anxious, best of luck deciding with a high deal of confidence whether this is a direct physiological consequence or whether this is, definitely not a psychological mediated response. So really this critique is just going through and looking at some of the kind of conceptual assumptions made in various places where the functional organic distinction is deployed, and then thinking about what does this tell us about the distinction and how it's used. So this is the Leishman criteria. I'm sure many people here will be very familiar with Leishman's organic psychiatry. It identifies organic disorders as ones that are based on a high probability that appropriate examination and investigation will then cover some cerebral or systemic pathology responsible for or contributing to the mental condition. And it's clear that the line of demarcation between organic and non-organic psychiatric disorders is not hard and fast. There's a substantial number of cases that can be continuing uncertainty. So again, here we're basing this judgment based on things like a high probability and responsible for or contributing to the mental condition. So I'm not going to go into these in detail because this is not really what we're going to be looking at. So there are various objections raised on a kind of conceptual, how it should be defined and what is it doing in terms of our understanding of the relationship between mind and brain and so on. For example, it's been criticized as dualistic. It's been criticized as maintaining an artificial distinction between psychiatry and neurology. Talking to lots of psychiatrists here, so I will leave it to you whether there should be, whether that distinction is artificial or not. That it's stigmatizing, that saying someone has an organic disorder is less stigmatizing. Lots of people who would object to aspects of psychiatry will suggest it's more stigmatizing, interesting enough, and that it leads to diagnostic incoherence. But one question you can ask is just, actually, how is it understood by clinicians? Right? Regardless of debates about its potential kind of effects and philosophical basis, how is it understood? And there's very few studies that have looked at this, but the ones that have are actually quite surprising. So this was a study by Richard Canaan and colleagues. It was interviewing and surveying neurologists about their kind of conceptual assumptions underlying functional neurological disorder. I can't remember whether it used conversion disorder hysteria at the time, but what we now call functional neurological disorder. And so this was responses to survey question number 30, the meaning of functional. So the first thing to note is that for neurologists, the most popular definition of functional was simply not organic. Yeah, so firstly, I find that surprising. And the next thing to note is that actually everybody kind of, if you went across the whole population of neurologists being surveyed, quite a substantial number of people would have defined functional to mean either abnormal brain function or abnormal body function or a psychiatric problem or not organic, which is, in many ways quite surprising, I guess, thinking about the influence of the functional organic distinction in terms of organizing our diagnostic categories and in terms of it's important in terms of clinical work. The fact that neurologists would really struggle to come up with a definition and indeed hold definitions which some people would consider to be contradictory. This was a fascinating study done by Benramo et al. In 2019. They surveyed 391 psychiatrists and psychiatric residents in Canada about the use of the term organic causes. So 55.9% reported using the phrase regularly. There was considerable variation in whether the phrase was considered stigmatizing, implied dualism, or led to unhelpful treatment. But I found this fascinating. Only 28.5% thought its use was appropriate. So a far larger number of psychiatrists used it than thought it was appropriate to use it. And when they were interviewed about this, they reported that they largely did so due to its assumed pragmatic function within in the healthcare system, right? So they would make very clear that these were, if they were referring a psychiatric patient with a psychiatric history, that these were organic symptoms to just guarantee that the patient would not be kind of like rejected or refused to be seen by other physicians, or they would, put down that they had excluded organic causes, to convince people that, that this had been done, and we can think of various reasons why this might be done in terms of, which medical specialties consider which other medical specialties job it is to do certain things. But in other words, they were using it as a very pragmatic tool, I'm sure in very good faith, to help the patients they were seeing get the best out of the healthcare system, despite the fact that they thought the term organic was in many cases inappropriate to use. So one question just to think about is, what is the conceptual scope of the functional organic distinction as it is deployed in kind of definitions of different disorders? And then we can also think a little bit about what's the relationship between the gathering of evidence for making the functional organic distinction for different sorts of difficulties. So one of the main things the functional organic distinction does is it calls it one thing because it's not the other. So functional can be used to signal, at least in part, not organic, and indeed vice versa. However, this is not a kind of 50-50 split, right? When it is used to signal not organic, it is not the midpoint of when it is used to signal, when organic is used to signal it's functional. And in fact, if you look at these, there are kind of subtly and importantly different manifestations of this. So let's think about the use of functional meaning not organic. So this is a common use of the word functional, meaning a disorder without an identifiable impairment to the nervous system sufficient to account for the etiology. So we often hear functional psychiatric disorder is often used in this way. So you might hear people talk about functional psychosis or functional depression, but it seems arbitrarily applied to some diagnoses and not others, right? So rarely do we hear functional insomnia or functional autism and many other sorts of things functional could be applied to in exactly the same way, but isn't. Another way it's used to mean not organic is when something looks neurologically organic but isn't. So this would be the use to do with functional neurological disorder, right? So these are problems that present similarly to neurological disorders, but without evidence for the expected impairment to neurophysiology. So for example, functional paralysis, functional blindness, functional tremor, and so on. And this is how neurologists tend to understand functional, as we've seen, but with some significant variation. But here we have kind of various inconsistencies. So tic disorders are diagnosed on behavioral characteristics. There is no kind of like, individual physiological, biological test which are involved in the diagnosis of tic disorders. And indeed, they require the exclusion of underlying neurological disorders. So in all intents and purposes, this would be a kind of functional psychiatric disorder, right? However, functional or psychogenic tics are considered to be distinct from tics diagnosed using tic disorder criteria, which are considered organic. And this is despite the existence of tic disorders that are attributed to the direct effects of neurological disorders such as TBI or stroke. And so here the conceptualization of organic in tic disorders covers what would otherwise be considered functional in other disorders. And I'll perhaps leave it as a bit of an exercise to the reader, as it were, but you can think of lots of sorts of disorders or lots of sorts of difficulties which just fit very poorly into the functional organic distinction. So migraine would be a kind of classic one. We can think of things like, so if we think of rarer migraine disorders like hemiplegic migraine, and I remember working in a stroke ward, and very occasionally we would get people who would turn up with psychosis triggered by hemiplegic migraine. So considering that migraine is to all intents and purposes functional, would this be a functional or would it be an organic psychosis? And there's lots of situations where actually the kind of the label on the tin of the functional organic disorder doesn't really fit actually lots of situations where you may think it should apply. So let's think about organic being used to mean not functional. So Leishman's organic psychiatry says that it should be diagnosed with a high probability that appropriate examination and investigation will uncover some cerebral or systemic pathology responsible for or contributing to the mental condition. No definition of high probability and appropriate investigation. Now, I want to mention here this, at first sight, this may seem like a bit of a kind of trivial, kind of criticism, right? Because you might go, oh yeah, but when we're looking at, for example, post-ictal psychosis, we know what the specific cerebral or systemic pathology is, and we know what the mental state is. And this is a very specific syndrome that has characteristics and can be reliably diagnosed. I'm not going to disagree with that at all, but what I want us to do is just think about the different relationships between how we make those diagnostic decisions and different sorts of organic syndromes. So let's take the example of delirium. Delirium is really fascinating. In the ICD-10, delirium is defined as disturbances of consciousness and attention, perception, thinking, motor, memory, psychomotor behavior, emotion, and the sleep-wake schedule. There is no specific criteria about establishing any kind of direct physiological consequence, and it's by definition organic. All right, so if someone has these in the ICD-10, they by definition have an organic disorder without the need for any other investigations. In DSM-5, they have this kind of like vague add-on reference to physiology. So evidence from the history, physical examination, or laboratory findings that's a direct physiological consequence of another medical condition. And again, I'm not suggesting here that there is no direct physiological consequence, or delirium is not a thing. If someone has like hyponatremia, a disturbance to their kind of blood sodium, and they have delirium, that can often be identified very reliably. But it is certainly the case that you go around medical wards and there'll be lots of people with delirium and lots of people scratching their head trying to work out exactly what's going on. So if we look at the distinction between what's possible to establish, what's typical in trying to establish what's going on, and what the diagnostic criteria say in terms of how to establish that, actually there's a whole spectrum of relationship between what the clinical evidence is, what the definition is in terms of it being organic, and what the diagnostic criteria states. We can look at hypercalcemia and anxiety. So this is a very different approach to establishing organicity. So imagine a patient presents with a severe agoraphobia and hypercalcemia. High calcium levels are treated and the anxiety resolves. So there's nothing in the presence of the anxiety per se that indicates an organic diagnosis, but this is a very hypothetico-deductive approach to understanding that something is an organic rather than a functional disorder in this case. Okay, so it's a very kind of like methodical, very classically medical. This is how kind of medical students are trained to think. This would be like the classic, detective work of a lot of medicine. And of course, in this case, the approach is very systematic. It's just worth mentioning that this also means that some presentations live in a diagnostic no man's land until they're resolved, or can flip between functional or organic. Let's think about post-ictal psychosis. I mentioned this a couple of times. It's just worth saying here that this is diagnosed on a seemingly reliable temporal relationship between seizure and psychotic episode, right? So typically between 3 to 7 days after someone had a seizure, they develop psychosis. Drug-induced psychosis is usually kind of diagnosed in a similar way. So the idea is that the main evidence here is a temporal relationship between the seizure and the onset of psychosis. And this would be different, for example, that someone just who has epilepsy, but then has psychosis. And they might not be, for example, diagnosed with a kind of organic psychosis. They may be kind of decided that they have a functional psychosis and they just happen to have epilepsy. We can also think of kind of like a behavioral disturbance, disinhibition, organic personality disorder, whatever you want to call it really, where a patient has brain injury, presents with socially inappropriate behavior. And imagine that the scans show a prefrontal cortex lesion. So here the diagnosis is based on a kind of inductive reasoning, right? So it seems likely that this person's socially inappropriate behavior is best explained by damage to their prefrontal cortex. And of course, you can get patients with, virtually identical damage to their prefrontal cortex who don't show any socially inappropriate behavior, and patients with no lesions who do. But in this case, it's based on a kind of seems likely inductive reason. So it's worth saying that in terms of the functional organic distinction, in terms of the evidence base used to make the distinction between what's functional organic, it can stretch from a very systematic hypothetical deductive approach to a just like Well, it seems probably is the case, based on just what we know about people, what we know about medicine, and what seems most likely. So there's a very broad spectrum of what counts as an adequate diagnosis of a functional versus organic. And in many cases, not clear cut and raises some significant difficulties. So I'm just going to talk about, some of the kind of conclusions we've come to really based on some of these, some of these kind of musings, I guess. So the first thing is that a functional organic distinction is unhelpfully linear, right? So it kind of has organic at one end and functional at the other. And the idea is that you're kind of placing someone along this spectrum. And again, we're not suggesting that there's no such thing as what can be labeled as organic brain disorders. There's no such thing as people who have, mental health problems without them, without any evidence of damage to the nervous system. It's just that the way that the functional organic distinction is set up, it's set up as a distinction, right? So you're kind of somewhere along this sliding scale, and it's up to the clinicians to kind of sit through, and this is what leads to lots of the long debates and ward rounds about to what extent this might be an organic problem and so on. And indeed, so it suggested a kind of stable proportion. So this is our idea that functional organic distinctions and helpfully static. It suggests that a stable proportion of a causal contribution to a particular difficulty can be reliably identified. So this is the concept of functional overlay, right? So the idea is that someone has some organic contribution to the cause of their problem, but their problem is bigger than would be explained by this. So they have a functional overlay. There's some aspect of the psychopathology which is adding up to make the totality of this problem, of which a certain proportion of that is organic. And so it often relies on this implied model of zero-sum causality and really encourages classification into discrete functional organic symptoms. And again, this clearly applies in some instances, but it really is in contrast to our best scientific understanding of neuropsychiatric disorders as arising from a dynamic interaction between personal, social, and neuropathological factors. So if we think of our patient with a brain tumor and anxiety, we can think, well, maybe that brain tumor has disturbed some of the neural circuits involved in the mediation of affect. But also, maybe they have a psychologically mediated anxiety based on the fact they have a brain tumor. And the fact that, the idea that this can be neatly packaged into a kind of zero-sum sliding scale parcelization of what counts as functional, what counts as organic, not only seems a little bit unrealistic in terms of just the clinical encounter, it seems a little bit unrealistic in terms of actually how we understand neuropsychiatric disorders. And again, not suggesting that there are no such thing as things that are, mostly explained by, structural changes to the nervous system, just suggesting that the way it's set up really, doesn't support this kind of complexity in perhaps the way it should do. This is a kind of important point I really want to drive home, as it were, but just the idea that the functional organic distinction depends on diagnostic arbitration. And this is sometimes against the best scientific evidence we have for the contribution of different factors to particular problems. So this was really brought home to me by some fantastic work by Eva Valera, who's been doing a lot of work with female victims of domestic violence. Now, if you think how domestic violence is conceptualized in psychology and psychiatry, it is almost completely conceptualized in terms of its emotional impact, in terms of trauma. Okay, so Eva Valera was very interested in brain injury. And particularly in concussion, mild traumatic brain injury. And so she did a study with victims of domestic violence and did a diagnostic interview in terms of brain injury. 75% of women who had experienced domestic violence had a single TBI, and 50% had multiple TBIs. And then when they looked at a comparable cohort, I believe, of women who had experienced violence but who had not had any TBI, you could see these marked differences in cognition, and indeed you could see disturbances to functional connectivity in fMRI. But importantly here, concussion is not organically diagnosable, right? You can't, organic or kind of concussion is something that's diagnosed almost entirely on history. So, if you get someone who has been concussed and has post-concussion syndromes, I think everybody would understand that's a mild traumatic brain injury, and there is an organic, there is a component which is involved damage to the nervous system, but it is not diagnosable organically in the same way a penetrating head injury can be. And this is so despite the fact that we have strong evidence for impaired cognition, disturbed functional connectivity. Victims of domestic violence are not typically considered to have organic difficulties, despite the fact that our best scientific evidence suggests that this should be a way that these problems should be considered to be an important component. We can also kind of look at the other side and go, let's have a look at a functional diagnosis, which does have high levels of clinically detectable alterations to the nervous system. So there's quite a few of these studies which have just looked at clinical abnormalities detected on CT or MRI in patients with first episode psychosis. Now, so these are just some of the results here. And the first thing to note is that clinical abnormalities are actually very high in this group. One thing to note here is that what were considered to be organic, were the sorts of abnormalities detected on MRI or CT, which changed the person's diagnosis from a functional first episode psychosis to an organic psychosis. But actually very high numbers of patients have clinically detectable abnormalities. Now, the majority of these are what are often dismissed as not clinically meaningful incidental, so they're small the white matter hyperintensities, they're small vessel changes and so on. But if we look at the research on to what extent do these changes predict poor outcome, to what extent do they predict poor mental health, poor social functioning, they predict poor outcome across the board, across the lifespan, all right? So even with these not clinically meaningful changes, the more you have, the worse outcome, the worse mental health, and the worse social adjustment you're going to have. So despite the fact we have very good evidence that here is a group of people with very high levels of clinically abnormal findings on MRI and CT, because it doesn't change their diagnosis, these are considered functional problems, all right? Despite the fact that our best evidence suggests that the fact that they have what you might call poor brain health is probably materially contributing to, in this case, having an episode of psychosis. So what we're seeing is this kind of diagnostic arbitration, right? Organic problems are not problems where we have good evidence that the alterations to the nervous system are involved in the presentation of the mental health problem. They are ones which can be arbitrated at a level of clinical diagnosis, even when our best evidence suggests this may not be the best guide. So one question we asked ourselves is, there's just years and years of all of these brilliant minds of neuropsychiatry basically going, well, isn't that functional organic distinction a bit crap? And, people saying that it should be lingers at the bedside, despite the fact that every contemplative mind has rejected it. And, philosophers of mind just kind of like, banging their heads against the bed and all of this sort of stuff. Why is it still here? Why is it still present? And there's been some really interesting kind of research on just the fact that it's really intuitively appealing, right? So this was a fascinating study by Moresco and Kermeyer, who found that even psychiatrists who are reductionists, right? Even psychiatrists who feel that all mental health problems are essentially brain problems, and when we have a sufficient understanding of how mental health problems reduce to brain problems, will reject our talk of kind of the mind as essentially conceptually incoherent. Even they use mind-brain dualism in clinical work. All right, so, and we know patients with unexplained neurological symptoms prefer functional. And again, this is not to criticize, patients as like choosing a bad choice, but just in terms of actually a lot of what we think about the relationship between mind and brain. Why is that intuitively appealing in that sense? And indeed, the hardware software is a recommended explanation for functional neurological disorder. And this is from John Stone and Alan Carson's group up in Edinburgh. Again, it's not to say that they're coming up with a kind of like COD explanation. They've come up with an explanation that works really well with patients who are experiencing these puzzling changes and have been told by often their neurologists that they don't have any kind of alterations to their nervous system that could explain it. So we have these intuitively appealing models, which fits quite well onto the functional organic distinction. And this is probably why it still exists. It's also worth mentioning that it's an absolutely fantastic basis for politics and kind of internecine fighting. All right, so we can see this kind of within medicine. So people with organic disorders are seen as more deserving of care, and the individuals are less responsible for their predicament. And organic disorders and relevant medical specialties are seen as more prestigious by both the public and by both clinical professionals. All right, and this is, so there's some fascinating research done on medical prestige and disease prestige and so on. And diseases which are more organic are just considered more prestigious. And it's also worth in the functional organic distinction is a long-held basis for challenging medical authority, so particularly in mental health. So this kind of Satsiana anti-psychiatry idea that the only valid problems that should fall under the remit of medicine are those that involve essentially a kind of diagnostically arbitrated alteration to the physiology is massively influential. I mean, Sats's work in terms of kind of libertarian approach to mental health is not massively influential, but his work in kind of arguing that only certain sorts of disorders should come under the remit of medicine has been massively influential. To the point where one of my professional organizations, the Division of Clinical Psychology, have taken this on as like a mantra. They love the functional organic distinction, despite the fact they think they're kind of like critical thinkers who don't take anything on face value and refuse to take on any kind of orthodoxy or pedagogy from medicine. They absolutely love the functional organic distinction because it's a very useful political tool, right, if you want to challenge particularly psychiatry. So it's also worth mentioning that, this was really kind of brought to our attention by Callum, survivor of brain injury on the team, and our work with Headway East London, who talked about the role of the functional organic distinction in terms of its use in kind of social power relations. So it can serve as a basis of testimonial injustice. So testimonial injustice has been discussed widely in medicine, but it's where people's testimony is not believed or is unjustly rejected. Now, the really key thing to bear in mind here is about unjustly, right? So, for example, someone with a memory disorder is going to produce, in some cases, less reliable testimony than someone without a memory disorder. But this doesn't mean to say that their testimony, therefore, must be rejected out of hand, or that it, shouldn't be considered on the grounds in which it's presented. And one of the things that lots of folks with brain injury mention, and has been attested to in kind of various studies in the literature, is that their behavior can be explained as either functional or organic, based on kind of the whims of the person that wants to do the explaining, and indeed their prejudice to a certain extent. So there's lots of fascinating studies in the literature about how professionals understand challenging behavior in people with brain injury. And so, what they often do, as reported in these studies, is try and maintain a good person explanation of that person, right? So, someone's very rude and aggressive. They'll suggest this is an organic difficulty, which means they can maintain the idea that this is a good person, but they've got some organic difficulties. And, this is a admirable and well-intentioned kind of conceptual move, at the risk of rejecting that person's complaints and concerns as ones that are not interpretable in any kind of everyday social sense, and rendering that person kind of socially inert. This turns up. Lots of folks we work with brain injury will sometimes say, when I start talking about something that really annoys me, people will say, oh, it's your brain injury, whereas other stuff they'll go, oh, you're being a terrible person. Right? And that tends to be based on the whims of the person or the professionals or the service. When actually in these situations, it can be very, very hard to make that sort of attribution. And so one of the things they asked us was just like, what does the research show about what folks with brain injury, what their experience is of, kind of organic and functional factors, and there isn't any. Right, so we found this quite surprising. In other words, quite a bit of my work is in psychosis, and the idea that you ask people about psychosis, what their experience is like. And that lived experience, such as, for example, the experience of auditory hallucinations, may be an important guide that guides the scientific process of developing neuropsychological models of auditory hallucinations. It's kind of completely accepted. It's uncontroversial. But the idea you would ask someone with brain injury about their experience of the interaction with brain injury and their own mental life, as it were, and that would be some useful insights that may help you inform something about the functional organic distinction. It's so out there for, I think, studies of brain injury, neurology, neuropsychiatry that it's never been considered and not been done. So this is our slightly challenging conclusion, and it's a question. It's not like we've not concluded this. It's the question we're kind of asking ourselves at the moment. So, is the functional organic distinction just a tool that helps determine treatment priority dressed up in the emperor's clothes of causation? Right. So the whole shtick of the functional organic distinction is it's about identifying causality. It's identifying causal contributions. But actually, when you're suggesting that someone has post-ictal psychosis, they have an organic psychosis triggered by seizures, are we really just saying that actually the treatment priority is stabilizing this person's seizures, is treating this person's seizures? To what extent may actually the functional organic distinction be discussed in the language of causality, but actually maybe what that talk is doing is actually a fairly pragmatic tool for navigating the medical system. So here are the conclusions of my talk. This is a summary. This is not kind of the things we've decided are true about it, but really just interested in opening up the discussion. So firstly, the functional organic distinction is unhelpfully linear and helpfully static. Current diagnostic technology, rather than broader scientific knowledge, defines the limits of functional organic distinction. And rather than a general distinction, is more akin to various local distinctions, each defined and importantly limited by contexts. And it has considerable social power in definition and application that actually to a large extent has probably not been questioned. And just as a final plug, we're running a study at the moment. We're interviewing clinicians about how they understand the functional organic distinction. I suspect some of you, I know this was emailed out to the Maudsley Philosophy list. If you're a clinician interested in taking part, we're interested in all sorts of clinicians. So do get in touch. And it's just an interview, and it's not an exam. Whatever you think the functional organic distinction is, or have doubts about it, we'd love to hear. Thank you very much.
Thank you very much, Vaughn. That was really excellent. So I think this is an invitation really to the audience, the participants, just to share comments and reflections and perhaps any questions as well for Vaughn. I'm aware of the fact that there are 50 participants, many of whom I'm sure have devoted a great deal of thought to this subject and a great deal of experience to draw upon. So I think in the interest of parity and making sure that people can contribute, I'm going to ask people to try and be as succinct as possible in the comments and reflections and questions that they make, but actually not to try and foreclose any avenues of discussion as well. So I think also just to try and determine some kind of order in which people can comment and contribute, if you could use the raise hand function, if you know how to do that, then that will allow us to work out who wants to speak. Okay, so who would like to start? Any initial comments, questions, points of clarification?
There is a question in the chat from Stephen Jackson.
Okay, would you like to read that out, Elisa?
Yes, so I'm not sure if it's really a question, but Stephen says that couldn't you pretty much make similar arguments about the role of diagnostic categories in understanding mental health conditions, pragmatic rather than intellectually useful? Stephen, I'm not sure if you want to elaborate or...
No, I guess the question's pretty self-evident. I mean, I was going to ask about that distinction between functional tics and organic tics, as someone who works on Tourette disorder, but it was raised in the meeting. But I guess the take-home message I got from the talk was that there were some pragmatic reasons why clinicians use these distinctions, while recognizing that they're not particularly useful in sort of diagnostically. And I guess my question is, whether the same sort of thing could be said for a whole range of diagnostic categories that are not mutually exclusive, with overlapping symptoms, etc., that we use them for pragmatic reasons, but don't really believe in them.
Any reflections on that, Vaughn?
So I guess you could yes and no. That the distinction I'd make with kind of psychiatric diagnosis in general, and I don't, it's always a danger thinking about psychiatric diagnosis in general because it's very broad and very diverse, is that there's quite a lot of diversity, that's probably not present in the broader kind of like mainstream diagnostic classifications in psychiatry, right? So in other words, the distinction between identifying organic anxiety disorder with a hypothetical deductive approach due to testing blood calcium is kind of very different from deciding that someone's inappropriate behavior is organically mediated. And so when we talked about the fact that they're local rather than global distinctions, I think it varies a great deal between diagnosis and diagnosis, actually.
Thanks, Vaughn. So just a reflection, really. So I think, Vaughn, what you've done is really it's kind of mapping exercise. It's a descriptive exercise of the uses of these terms in different areas of neurology and psychiatry. And perhaps philosophically, you could describe it as indebted to pragmatism. It's indebted to the Wittgensteinian tradition that the meaning of a word is its use in the language, and that's what we're trying to do, really. But given that this, in a way, is a descriptive exercise, I suppose one thought or reflection on this is, do you have a sense, Vaughn, in your reflections on this, whether the problems here are primarily conceptual, or so that in actual fact we need better concepts to organize the way we think about causation, for example, of various sorts of troubles that people present with? Or do you think that the problem fundamentally is an absence of knowledge? So we haven't done enough studies yet. We don't yet have enough facts to know what causes things to happen. And if we knew more about what causes things to happen, then we would be able to allocate causes more comprehensively. And obviously we can run with the ball then about how we think about causation and how we unpack additive causation and synergic causation and different ways of thinking about social, psychological, neurobiological cause and so on. But having sort of written, really taken lead on this paper and kind of wrestled with this topic as deeply as you have done, do you have a sense of what the solutions would look like? And go back, primarily a conceptual problem, or primarily a problem of the provisionality of knowledge and the fact that we haven't done enough research yet?
I'm going to give that terrible answer where I got both. But there are clearly some things which if we knew more about, we would be better able to understand. For example, the causes of delirium, right? Which on a day-to-day medical basis, like psychiatrists and physicians do an absolutely fantastic job of helping folks with delirium. But it's true to say that actually there's probably a lot more to learn about the sort of things that cause delirium, to be able to deal with that more effectively. But it is also the case that the fact that the functional organic distinction does have some of these properties, for example, like being a kind of zero-sum approach to causality, which makes it actually, rule out lots of the mainstream ways we understand neuropsychiatric disorders. So the idea that something would be more functional one day and less functional the next day is very hard to fit into the kind of clinical practice and deployment of the functional organic distinction, despite the fact that this may be a fairly uncontroversial way of thinking about neuropsychiatric disorders. The idea that is a dynamic interaction between various, even with something as simple as brain injury, right, has definitely damaged some of the circuits involved in the mediation of affect, but also that doesn't contribute a stable amount of the causality for anyone's problems. So, I don't think it's possible to answer that question in any way. And I think probably one of the conclusions that I've come to is that actually the functional organic distinction is probably a little bit of, in terms of its broad understanding, probably a little bit of an unhelpful way of doing things. But in terms of local distinctions, it's a local distinction that manifests in different places and in different ways with different levels of reliability. And some of those will yield quite well to new knowledge. But some of the ways that the distinction is conceptualized at the moment is probably a bit of an obstacle in some cases to a better understanding.
Thank you for that. Any more comments or questions at present? Rob?
Yeah, I've got a question. Well, it's not really a question. I was just thinking that it's a little bit like the biopsychosocial distinction, isn't it? And I was thinking of you talking about boring ward rounds when people sort of endlessly go on about, is it functional or organic? And we do that with the biopsychosocial distinctions as well. And I was thinking, maybe they're not so boring, because maybe what we're doing is exactly that kind of, well, it is about pragmatism, but it's also possibly about ontology when we're not quite sure what is what, where we're hopefully, when we do it well, we're sort of wrestling out, a bit like a coroner deciding how much guilt to put where when someone's died. We're trying to work out what should go where, and we are constantly changing it, and it does rightly change. And perhaps we don't give patients and their carers enough say in that, as you're saying, in some disorders we do, but with brain injuries we don't. But actually, when you have, say, an MDT in the room and everyone is sort of making their contribution, that is what a good formulation is, isn't it?
So one question is just, is the language of or rather, what are the advantages and disadvantages of doing it in the language of causality? Yeah, which has some, probably useful aspects, and it has some unhelpful aspects as well, right? I would agree this also applies to the biopsychosocial model. But interestingly, that's, it's kind of a different level of causality there, right? It's kind of, it's not intra-individual. And so there are different, so if someone goes, oh, it's their leaky roof, then maybe that is a different sort. All people are doing are prioritizing, potentially, right? The sort of interventions that people need. So I guess one way of asking that question is, imagine if we didn't try to solve all these problems in terms of causality. What benefits and difficulties would that have? And I'm sure there would be some definite difficulties, because causal talk is certainly very relevant for medicine, right? And there are some cases where that can be very relevant and directly lead you to interventions, but in some cases it may not be. And with some of these kind of like, it seems like sorts of influences, maybe they're less helpful there, where there is a clearly defined pathophysiology for which you can identify, test, verify, and then intervene on. So I'm kind of like free associating here, but I just wonder, I think you're quite right, Rob, and I just wonder the extent to which we are aware of the limitations of some of that talk.
I mean, I guess one of the things is that when you're in the biological or the organic domain, I suppose you're in the realm of causes. But when you're in the other realms, and you're not just, but you are, it sort of identifies you in that realm. With the other domains, I guess you're on less even ground, and particularly in the social domain, as you say, it can all get very mixed up and even start to destroy the other domains if you're thinking of sort of critical social theory. But it's, yeah, anyway, it's very interesting. Good talk.
Well, just Tony, do you want to come in?
Tony, Mark, and Marcus have hands up, I noticed.
Oh, actually, great. Okay, Tony, do you want to come in?
Yes, thank you. Very interesting talk, Vaughn. Just so good to hear these arguments put slightly differently and illuminatingly. First of all, I think you touched on the moral dimension here. And I think that's why the organic functional argument sort of persists, because there's a real moral ethical dimension, which I think is very, we tend to play down. So not only is a person's behavior excusable if it's down to their brain lesion, they've got a legitimate sort of excuse, they're not responsible, but in general, organic disorders are seen more like something that befalls upon you, whereas in general, psychological, psychiatric, functional disorders are somehow your fault a little bit. And so I think that's why there's so much sort of energy goes into the distinction. But what I really feel, and just it probably is what Rob was saying, that it is those interminable war drowns. I used to really enjoy them, and I was sort of guilty of perpetuating them. It is a very useful heuristic to consider the distinction. And I think it's not so much about causality, in which one of them has a primacy in terms of causality. It's about levels of distinction, levels of explanation, I'm sorry. So that's why you can be a complete monist. Everything's due to the brain. It's, there's nothing else. And yet that doesn't really, doesn't make for a useful or interesting conversation, because at the level of explanation, social or psychological understanding can be much more useful. And so, and this goes back also, the same argument applies to the biopsychosocial model, which is, Derek Bolton and others have said, everything boils down to physics and chemistry because there's nothing else. It's all physics and chemistry. But then if you want to understand why a person behaved in a certain way, it's probably easier to think about what their beliefs and attitudes were rather than putting them in some brain machine that would tell you what their molecules are doing. So the levels of explanation will never give you a distinctive answer about which is right or wrong, or the percentage of which is wrong. But the process of trying to determine how to explain, I think, is a useful heuristic. It's a humanizing activity for the clinician, and it probably does lead to sensible decisions in terms of treatment, interventions, etc.
So I'm gonna push back on that a little bit, not because I think you're wrong, Tony, but I'm just aware I've had two psychiatrists trained to do exactly this. All right, spend for like however long, 10 years of postgraduate training, drilled in going through these different levels of explanation. Who do very good work in terms of supporting treating patients, telling me that this is a useful. It may not be conceptually kind of coherent, but is a useful way of going through and that kind of tackling problems. Now, I'm not gonna doubt that. I'm not gonna try and pretend that actually this is all a fiction and we're not helping people. But there's one question which is just, are there better ways of doing it, right? And what hidden assumptions do these ways of doing things do? And so this has really been brought to our kind of minds by like lots of the folks with brain injury we're working with, who actually go, you know what, a lot of that stuff is kind of unhelpful, to be perfectly honest, and not a lot of it, but they have all got situations where they feel that the functional organic distinction has been used in a way that they've found unhelpful. And it's not, I just want to make it clear, it's not just clinicians, by the way. but they very clearly say that actually it is not just a kind of like diagnostic or formulative tool. It's also a tool, and this is where your moral aspect comes in, Tony, right? Where, you know, it can be used as a way of, you know, kind of disempowering us, or in you know, in quite convincing ways. By the way, we also see this kind of in the scientific literature, right? So I'll give you a brief example we talk about in the paper. So there's this very famous case study of a chap who developed a sexual interest in children, and he got a brain scan. There was a brain tumor, right? And they took the brain tumor out, and then his sexual interest in children went away. And then he started developing a sexual interest in children, and they did a brain scan, and the brain tumor had grown back, right? And so this is very much described in terms of like disturbing one's sexuality. It altered the circuits involved in the normal regulation of sexuality. Now, if you look at this other tradition of case studies, which is folks who have neurological disorders who suddenly develop a talent for art, right? It's very much described in terms of the brain disorder releasing this talent, right? So you can see the implicit assumption here, whereas for one, you know, for one group of people that developed a new way of kind of doing things, it was something inside of them that's been released. And for another group of people, it's something that's been damaged. So there's lots of these kind of implicit assumptions about what the role of the organic thing is doing that's inseparable from the behavior and from the, you know, the interpretation of what that person is doing. That, exactly as you said, Tony, steps beyond kind of like science, and, you know, goes into kind of like moral interpretation of you know, how acceptable we feel this behavior is. There's lots of interesting studies about people who feel their sexual orientation has been altered after kind of brain injury and so on. So, you know, I just want to say that, you know, it may well be, and I find it a very useful way of going through and kind of formulating problems. But, you know, thinking about what the disadvantages might be and what the alternatives could be, right? So, for example, you know, Sam, our philosopher on the team, is very into kind of 4E models of cognition. You know, what would a kind of 4E model of functional organic distinction look like? So actually, I think this is a very long-winded answer to go, you could well be right, but considering the conceptual problems, it's probably worth trying to fix some of them and trying to develop an alternative, or alternatives for aspects that are not working so well.
Thanks. I won't come back on that. There's so much there, but let someone else have a try. But thanks very much, Vaughn.
Thanks, Tony. So I see also that Mark Edwards, I think, and Marcus Ruber also have raised hands. Mark, do you want to contribute now?
Sure. Thanks very much, Vaughn. A great talk. I suppose just picking up on some of the points, you know, that a critical bit of this is, which you mentioned, is about the utility of it. And there's a certain pragmatism in this distinction, which is about acute medical care. I'm not suggesting that it's necessarily always correct, but the idea is that if we label somebody with an organic something, that's something that we need to do something about now, and the functional stuff can wait. Obviously, it typically is just dismissed and sent away, but there is that sort of pragmatic use of it in acute clinical practice. But I happen to agree with what you said. I don't think it generally has much utility, really, because what we're doing is, what we want to understand is mechanism. So that's at least one bit of what we want to understand. But the mechanisms within these labels, these two labels of functional organic, they're likely to be multiple. And particularly for the organic label, the mechanism is really at the level of description of the available technology we have. And that's what is putting the bar, if you like, saying that this is organic versus something which is functional. And even within the functional category, there's likely to be multiple mechanisms. And the problem I see is that particularly with the functional category, once it's labeled as such, people stop thinking about what the mechanisms could be. And they also do it the other way around from the organic point of view, because if the patient is just seen as a passive recipient of illness, or of disease rather, And as Tony said, that means that they can enter the sick role, they don't have those responsibilities, but it makes them into a passive thing, really. And therefore, other explanations for aspects of their illness experience are not thought about. And the mechanisms for those and the treatments for those are not thought about because they have an organic illness. So I find it a very unuseful label. And I agree with you that we could do a lot better.
Yeah, thank you for that. And I think my take is that it's sometimes useful, but there's a big grey area. And actually, Quinton's point about to what extent is this a knowledge problem versus a conceptual problem, I think is the key issue, actually. But I agree with everything you said, Mark. Probably apart from the very last bit where you said you don't find it useful, I find it moderately useful. Despite what you all said. That's fair enough. I mean, I use it every single day of my working life. Right.
But at the same time, I think we could do better. Put it that way.
Yeah, I would agree with that, definitely.
Thank you very much, Marcus. You're muted, Marcus.
Am I still muted?
No, we can hear you.
Good.
All right. Sorry. So I just thought it was useful to consider this functional organic division in the context of how symptoms are negotiated between patients and doctors more generally. The sociological activity. So there's this thinking that symptoms become commodities in this context. The patient says, "I have this discomfort in my chest," and the physician translates this into chest pain, and then picks up the phone and rings the cardiologist and says, "I've got a patient with suspected acute coronary syndrome," and the patient has a certain test. So the functional and organic divide has a similar effect. Mark was alluding to this. If you say it's organic, then you can get your MRI scan. The psychiatrist can get the neurologist involved. If you say it's functional, you go down a different line. The significance of this, I think, is that it makes it even more ingrained. The sociological activities are difficult to change and difficult to work against. But I think this distinction, as you've so nicely demonstrated, is so unhelpful, but at the same time beguilingly simple, that people who have thought about it should really work hard to find a better way of talking about illness. So my specific question was, Mark is also involved with patient organizations. I'm involved with patient organizations who are fighting for more doctors to use the functional term and to abandon, for instance, terms like dissociative or psychogenic. What's your prediction? Where are we going to, in 30 years, have to find a new word for functional, because functional has been used up in this moral and sociological quagmire?
So that's it. I mean, it's hard to say, really, isn't it? I was at a British Neuropsychiatric Association meeting, and I did my one of my clinical doctorate on essentially what we at the time called conversion disorder, and then some years later I was at the British Neuropsychiatric Association, and firstly, after being away for, everyone was calling it functional neurological disorder, and there were loads of bloody neurologists there, and I was just amazed at how quickly actually it's changed. Someone there, one of the neurologists there, did kind of say to me, "Oh yeah, but you do realise, like, all of the neurologists who believe that here, right? And actually, there's still, a lot of work to do." But it could be a really positive change, and it's just there's lots of changes. There's lots of terminology in medicine that their terminology has become invisible, right? So we don't think people with strokes have been struck down by God. We don't think people with seizures have been seized by spirits. We don't think people with influenza are being influenced. And so, you know, there's the terminology as a label versus the kind of conceptual implications that particular terminology has, right? And you could probably make a good argument that, you know, saying that someone has a stroke has no relation to them being struck down by God or otherwise, right? It's a very kind of, you know, so it would just be fascinating to see. It's so fast moving, Marcus. And I have to say, one thing, this is probably a little bit off topic, but one thing has really surprised me is the kind of alignment between patients and medics with regard to functional neurological disorder. In that it used to be very, very contentious and very conflictual, and now lots of people seem to be on the same page. And I wonder whether this is actually a model for how things should be dealt with. And you know, that I don't think that has been particularly well investigated, right? So what has been so successful, considering that like 15 years ago, actually there was a fundamental disagreement about the nature of these problems, to the point where patients were kind of often largely rejected from medical services. I think it's a really interesting, and probably will have a lot to say to the broader understanding of the functional organic distinction.
Well, thank you very much. Perhaps we can make functional be more longer lasting if we work very hard on a better understanding and definition of it.
Thank you, Marcus and Vaughn. So Marion Brown, I see you have a hand raised. Would you like to contribute?
Oh yes, sorry, I'm coming from a sort of outsider's perspective. I've written quite a few articles now about patient experience, and I know a lot of people who have become diagnosed with functional neurological disorder over the years, and more recently, and their history, you know, speaking about the etiology, their history has been that they've been on antidepressants or benzos and been with and tried to come off them, and have run into terrible problems trying to come off the medications. And so, and actually the functional, it is that the nervous system not working. So I mean, it is like not working anymore. So the functional is probably a fair enough term, but what the feeling is it's being misdiagnosed as a psychological problem or a psychiatric problem. So there's more drugs being thrown at them. And so what's happening is the whole nervous system is being messed up, and the role of the psychiatric drugs, and especially antidepressants, which are largely seen to be safe and effective, seems to be being missed. And you know, you said there is very little, Vaughn said there's very little evidence of patient experience, and we've been collecting patient experience. We've had a petition in Scotland and a petition in Wales collecting evidence, which we've now written up. And so really, can I say, please, can I look at this? So what's happening is, like, you know, that the nervous system is being left in an unstable state. So it isn't functioning, you know, people are suffering functional problems. So the wiring is messed up, is I think what we're trying to say. So that's really what I'm saying is please, can we not overlook the effects of the CNS drugs which are being used for psychological or psychiatric problems.
Yeah, I think, no, it's a really important point, actually. And I think, you know, when we're talking about these kind of sociological issues of what gets, you know, ascribed functional organic, you know, based on, you know, kind of what people think is most convenient. And I don't mean that in a trivial sense, it's often very well intentioned. You know, I think there's a kind of whole area of, you know, kind of problems caused by medication or the treatment and the difficulties they lead on, and the extent to which they're interpreted as functional organic, or, you know, how a complaint's understood in that particular, you know, in that particular arena. And that's barely been investigated, actually. And I think it's probably a very fruitful avenue to look down.
Thank you very much.
Thank you very much, Marion, for that comment. Gareth, you have your hand raised.
Yeah, thanks. Quentin, thanks, Vaughn, for the talk. I've heard it before, and it was really good. Second time, better second time around. Thought really very thought-provoking. I don't think I've got anything to particularly say about the term functional, which seems to me a very complicated sort of word historically, and so forth. But the term organic, I really want to champion. I think this is a very important concept, actually. And the idea that it's all to do with causation, I think, is misleading. I think Tony's sort of making points about this. We confuse ourselves if we just try to tie it to causation. It's also about level of organization, which is really an ontological claim. It's not a causal claim. And of course, this is difficult for us as people who are sort of practicing, clinicians and not ontologists. But, basically, whenever we're seeing somebody, we're always having to ask the question about a symptom. Symptom of what? And that's always going to, in some sense, lead us to a question about level of organization. And of course, where do our diagnostic systems come from? They come in large part from, continental Europe, sort of France, Germany, 1900s. And there, the concept of the diagnostic hierarchy made absolutely essential use of the notion of organic. I mean, remember, it's right at the top. And just from a praxis perspective, I've been very much I've been thinking that this organic level of organization is actually very important. And I spent 10 years working in a crisis team where we saw a lot of complex psychosis, psychosocial complexity, basically, essentially a lot of complex reactions to stress and so forth. For the last few years, I've been working in King's in old age psychiatry, where we see a lot of delirium. So in COVID, we've seen masses of it. And, delirium is the classic organic mental state. And we've had lots of referrals from doctors, physical health doctors, with people in delirium asking us the question, is this a new onset psychosis? And the answer is no, it's delirium. And delirium can involve psychotic experiences. So that's been very important for them to know. And of course, it's important for us to know as psychiatrists, if you're seeing somebody who's developing an abnormal mental state, is this best thought of organically? Because that has all kinds of implications in terms of treatment priority and so forth. But it also, as Tony's alluding to, it has potentially ethical implications as well. So I think we ignore this concept of organicity or the organic level of organization at our peril, actually. It's very important, I think, that we get our heads around it rather than just sort of not use it because we're embarrassed about being dualists or something like that. I really think that's sort of a separate philosophical worry. Anyway, that was a bit of a rant.
No. And so it's a really interesting. So firstly, just to clarify, I'm not suggesting we get rid of, I don't like the word organic, but I'm not suggesting we get rid of, stop considering what we might typically call, organic. One comment is, it's a really fascinating way of looking at things in terms of organization. But then we have to think about the diagnostic system and indeed medical training, which is very much in terms of causation, right? So how would a diagnostic system or just kind of medical training look different if it was based on kind of like an organizational hierarchy rather than causation claims? Now, I suspect psychiatrists and neurologists would probably not, barely feel the bump in the road, because this is not unfamiliar territory. But cardiologists might find it a bit of a shock to the system, and considering that a lot of medical training is very much based around this kind of, this is what we do. And I'm not suggesting that this is necessarily a bad thing, Gareth. I'm actually thinking that's a really fascinating idea, and I wonder what this would look like if it was cashed out in terms of a different way of approaching things. And this is basically kind of the project we're working on at the moment, right? What would alternative conceptual bases look like if it was cashed out in terms of clinical practice? And I think that's a really, really fascinating example of a kind of alternative way of conceptualizing something.
Thank you, Vaughn, and thank you, Gareth. There's just a comment in the chat which I want to make sure that we don't miss, which was from John Keedy. It was a reflection on Tony's earlier point, Tony David. Following on from Tony's point, how might or would you apply this functional organic distinction to conditions such as personality disorders? Any thoughts on that, Vaughn?
So not really. I mean, so there is a fascinating literature about organic personality change, which is not quite what you mean. So, you know, kind of classic personality DSM personality disorder would be considered to be a kind of classic functional diagnosis, right? That is therefore not explained by any primary changes to the nervous system. There's no direct you know, kind of explanation in terms of direct physiological consequence. But there is this whole fascinating kind of area of organic personality change. I think this is really fascinating, partly because we have these very clear changes, which are like after brain injury, after frontal lobe damage, people have organic personality change. But there's also lots of these like fascinating, you know, slow evolving, sometimes called insidious changes to personality. You may see in, for example, older adults that never turn out to be dementia, or maybe you know seem not to be real sudden changes, and yet which are thought to be on the borderlines of organic personality disorder. So you know, I think it's a very interesting area. I don't, you know, I've not done much except to you know, think about some of the challenges of organic personality disorder, which there's quite a bit written, and it very much applies to what we thought about, and particularly what the folks with brain injury we're working with have thought about, which is that the area of personality, even after brain injury, is heavily contested. You know, people will frequently say that, you know, I'm working with someone who spent a long time to come to the conclusion that the people around her, when they say she lacked empathy, were correct, but that people still made unfair judgments on lots of other things that had occurred since, you know, since she had her brain injury. Like, you know, people were, you know, dismissed lots of her concerns because they felt they were organic in nature.
Thank you. Thank you very much, Vaughn, for those reflections. We're sort of entering the home stretch now. We started slightly late, but we should be tying up fairly soon. I just listening to comments that people have been making, perhaps just a couple of thoughts that spring to mind. It does seem to me that the exercise in which doctors of various types engage when thinking about causes of behavior, influences on behavior is important, and it's obviously tied in to the point that Gareth articulated clearly. Often our causal partitioning of the world presupposes a hierarchy of levels of thinking about what the world is made up of, the types of things that the world is made up of. So, you know, theories of ontology. But I think from a medical point of view, and indeed actually from a psychological point of view, the exercise of determining influences on behavior and the openness to recognizing more than one influence on behavior or some type of difficulty or other is important, because it's a basis for identifying remediable change. So if understanding a complex system, you can identify several things within the system which are influencing a particular set of difficulties that somebody is having, then that allows targeting of intervention at different levels. And it may indeed be that some of the causes that you identify are not remediable, but that's also useful to know as well. And I suppose the other point is thinking about causation. I think the phrase differences that make a difference is always useful to bear in mind, because I think this goes back, I think, to the limits to knowledge and indeed actually the limits to knowledge at the bedside, but actually also the provisionality of scientific knowledge, the limits of scientific knowledge, that in order to actually do something useful for somebody, you don't actually need to know everything about them. You don't need to know every level at which their bodies and the world around them is constituted, or indeed how all of them causally interact. We'll probably never know that. And actually, we just, our knowledge just gives us a handle on certain things which are eventuating in the difficulties that people have. So I think that sort of perhaps somewhat more sort of recognizing the inherent provisionality of what we're doing whilst also endorsing it as valuable, I think is important. But the other thing that the other point I wanted to make, Vaughn, about the this paper in your talk, actually, which I think is really interesting. I don't think I've ever seen a talk which actually maps such a large area of medicine and examines it through the lens of a particular set of concepts. And I think what it's revealed is, in a way, how, at the one hand, sort of rhetorically or discursively, medicine really presents itself as an enlightenment project with universalizing claims and a taxonomy that can be applied to understand the types of problems, health problems, or physical problems, psychological problems that people have. But in actual fact, when it's examined in detail, what we have are lots of little sub-traditions that have arisen around the management of particular types of disorder or problem or health problem that people have. And in a very Wittgensteinian kind of way, actually, you have a lot of language games that surround those particular sorts of difficulty, which don't map or translate into a universalizing discourse, despite our rhetorical aspiration to be able to do that in the way that we have DSM-5 and ICD-11 and so on. So different problems have different traditions. Medical traditions have arisen around different types of problem with different types of knowledge base and different conceptual armory to kind of address them, and different sort of therapeutic interventions. But I think, just to go back to a point that you're making, Vaughn, but also that Mark Edwards is making, others, is actually what all of this begs really is that at this point in the evolution of medicine and psychiatry and so on, actually can we develop a set of theories and ways of thinking, parsing causation, identifying mechanisms which are more universalizable and can be translated into clinical practice. And so I think that kind of remains a challenge, because I think what the paper has revealed is that is not presently the case. There isn't that consistency across conditions and across disorders and specialisms.
So I'll just finish by, it's not really speculation, but just kind of drawing a few parallels. So I'm really fascinated by meteorology. I'm not a meteorologist in any sense, but I'm just interested in the way that they understand problems. So obviously weather is a very complex system, and you can disturb things at quite a local level, but there are very stable mechanisms which are reliable, and when affected will have a big effect on lots of things, right? So it strikes me that the weather is quite like the problem we're thinking about at the moment. You could say that there are kind of functional aspects of the weather, or organic aspects, which are like the structural aspects for which the other stuff work. But would it at all be useful in making that distinction? Right, so if we look at other places where they're trying to use kind of complex systems approaches to understanding phenomena, are these sort of like broad distinctions between kind of like stable structural things and more local changeable things, to what extent are they useful? And I think that's a really interesting question to ask, that perhaps could do with some more explanation, that may well apply to medicine in lots of, particularly to neuropsychiatry, which deals with these different interacting levels, which are not clearly distinct, but which clearly show kind of like broad boundaries for which, over large stretches have different properties. And so maybe by looking to other sorts of disciplines that make sense of complex systems. We may think of different ways of trying to kind of make sense of different interacting factors with different properties, which are not essentially based on what we can see and what we can't in the nervous system. I don't mean to oversimplify, but very much the roots of where the functional organic distinction has come from.
Well, on that note, Vaughn, those very interesting sort of final suggestions and invitations to future work and understanding, I think we should all extend a vote of thanks to you for really excellent talk. So I'm going to sort of clap, but there'll be a sort of symbolic clapping from others, iconic clapping. But thank you very much. That's fantastic.
Well, thank you for turning up. I'm surprised there are so many people here with a shared interest. So no, thank you very much. It was very kind of you to invite me, and thank you for everyone for coming.
Great. Bye, everyone. Bye, Vaughn. Thank you very much.
Thank you.